First is to anticoagulate the patient. So as soon as we open and whenever we are ready, we ask the anesthetist to heparinize the patient. So heparin is given to the patient in order to keep the blood thin. So we give around 4 milligram per kg of the patient. We wait for about 8 minutes, and we think generally within 8 to 10 minutes, we achieve the amount of anticoagulation that is required. After that, we cannulate the heart. We put some pipes or tubes into the heart. So that's the cannulation part of it. And when we cannulate the aorta or the right atrium, or we cannulate the aorta and superior and inferior vena cava based on the access that is required to perform this surgery. The third thing is very careful monitoring, both by the perfusionist and the anesthetist, will be happening, not just in the form of the monitor, but periodic arterial blood gas analysis will keep happening in order to maintain the whole process as physiologic to the body as possible. Also, they will be monitoring the anticoagulation level as well periodically to make sure the blood remains remains free of any coagulation, and we don't want clots in the circuit. So with all this, we are ready for taking the patient on cardiopulmonary bypass. While on cardiopulmonary bypass, the perfusionist will maintain the perfusion pressure, the pressure at which they need to give blood back into the patient in order to make sure that the perfusion of the entire body is adequate. So they also manage the pump flows. They manage how much to flow for a particular patient of a particular body surface area at that particular temperature to which the surgeon would have asked them to cool. So that in turn is the temperature management. Also, there will be central nervous system monitoring by the anesthetist to make sure that there is no hypoperfusion of the brain. And also pulsatility. We believe that a pulsatile cardiopulmonary bypass is more beneficial to the patient, and so the pulsatility is maintained. So before we start the surgery, what do we plan? How does the sequence of events go about? We first do the circuit selection based upon the body surface area. The perfusionist has different types of circuits available for use. So they will do the circuit selection and the priming selection. So they want to know what sort of prime they can use, and hence they go in for the priming. They use the anticoagulation, then the cannulation. We initiate the bypass, and the perfusionist maintains the bypass with the help of the anesthetist. We use certain medications for myocardial protection, which I will come to later on. And once the surgery is over, we need to wean the patient off the cardiopulmonary bypass, and we need to terminate the cardiopulmonary bypass. So the patient's own circulation, which is now corrected after the surgery, will take over the function completely. So I spoke about this a little bit already because I think one of the participants, Garima or somebody, asked which fluid. So it'll be sort of a repetition, but anyway, crystalloid solutions are used or colloid solutions are used. These are crystalloid solutions, like I said, it leads to decreased colloid osmotic pressure. So also there can be extracellular fluid or water retention. So generally we don't prefer it in pediatrics, but our adult colleagues, they use it because they have the capacity to withstand this amount of dilution. The adults have the capacity to withstand this amount of dilution, and they will filter it out. So the colloid solution, which can be whole blood or packed red blood cells, and like I told you, FFP or albumin. These are the choices that we have. The idea is we need to maintain the colloid osmotic pressure, and we need to maintain the hemoglobin levels of the patient while on cardiopulmonary bypass. Keeping these two in mind, the choice is made. Albumin is a better choice because it decreases the interaction of blood components with the circuit. So this is called as the priming volume. This is called as a prime, and priming volume is the amount of volume which is needed. And it's necessary because we need to de-air the circuit. As you all can understand, we cannot have air in the circuit, at least on the arterial side, because you'll be giving it back. And if you give back this air into the circuit, then it is going to cause air embolism in the patient. So it has to be free of air. So the one way to remove air is to displace it with fluid. So that's where the prime comes into use. But we need to be very sensitive or aware about the volume of the prime that we are going to use, especially in neonates and infants, because it becomes the main cause for hemodilution on pump. So not just it dilutes the blood, even the coagulation factors, formed elements, the drugs that the anesthetist or the perfusionist is giving, everything gets diluted. So they're very cautious about how much priming they're using. So like I said, heparin is what is used, and it binds to antithrombin 3 profoundly. It facilitates the native ability to inhibit the plasma coagulation, and it acts through inhibition of factor 2A, that is thrombin, and 10A. So it is monitored by measuring what is called as the ACT, that is the clotting time is measured. So the initial dose is 4 mg per kg, and we try to achieve this ACT of around 480, what we consider ideal to go on cardiopulmonary bypass. Let's say we fall short of it, then we repeat or give additional heparin, but not at 4 mg per kg, but depending upon the ACT achieved, we give this. At times, there could be heparin resistance. So in that cases, we use antithrombin 3 concentrate or FFP in order to bring up the ACT of the patient. So once we have done with the surgery, we need to reverse this. So to reverse or neutralize the heparin that we have given, we use protamine. So this is derived from salmon sperm, and it is used to neutralize heparin. And we use it at 1:1 ratio. We should not exceed 3 milligram per kg, because protamine itself has a mild anticoagulant effect, which is independent of heparin. So we think that the patient is bleeding too much, and if we keep giving protamine to that patient, in fact, it gets counterproductive and the patient starts bleeding even more. So next, coming to hypotension, which is one of the complications of protamine, and it is because of the activation of complement system. So initially, whenever we start giving protamine after the surgery, the anesthetist gives a test dose, and we wait for some time to see if the patient is having any reaction to this protamine. If they do not have it, only then they continue with it till we are happy with the hemostasis. And in case hypotension occurs, we can counter it by giving calcium. We also go on to give hydrocortisone, and because it's an anaphylactic shock, that's the way we treat it. At times, it can be quite overwhelming, where we need to go back on cardiopulmonary bypass, and then we have to come off again. So this is about the anticoagulation or procoagulation. I mean, the two drugs that we use, that is heparin for hemodilution, I mean, to anticoagulate, and protamine to reverse the action of heparin. Now, I was talking to you about cannulae. I already told you this, that there are 3 types of cannulation. That's the arterial, venous, and the cardioplegia. Arterial, generally, we put it into the aorta, but sometimes if it is arch surgeries, now we may cannulate the innominate selectively. And sometimes you may have to cannulate the ascending and descending aorta. But generally, of course, it's in the aorta. And venous can be in the right atrium if we don't have to open the right atrium. In case we need to open the right atrium, then we are going to cannulate the superior and inferior vena cava. Cardioplegia solution has to be given to the heart in order to stop the heart. So this cannulation is done in the aorta. So the target for venous cannulation is generally right atrium, SVC or IVC. And like I said, arterial cannulation, usually it is ascending aorta. So oxygenated blood is returned to the patient via the arterial cannula. So like I said, we give 4 milligrams per kg of heparin to achieve an ACT of at least 480. Anything above is okay. And we monitor this anticoagulation. So other than aorta, which is the proximal aorta, which is the most common site, it can be innominate artery, like I told you. It can be distal aortic arch. We may even cannulate the femorals or external iliac. Say we are operating on the patient for the 2nd, 3rd, or 4th time, then as you can imagine, the heart will be quite stuck to the sternum, under surface of the sternum. So when we are opening, there is a chance that we might injure the heart, So at that time, we cannulate the femorals. We go on bypass, so we know the heart is safe and also it is empty. Chances of injuring the heart will get lesser. So in that case, we cannulate the femorals or external iliac, and then we open the chest. Depending upon the kind of surgery, if you want the whole of the arch vessels and the ascending aorta, then the arch to be free, we may even cannulate the axillary or subclavian. So that is, the choice is based on the operation which is planned. And in adults, maybe because of the atherosclerotic disease, we need to see where in the aorta we need to cannulate. So those of you who are perfusionists in the audience are very familiar with this. For the rest of you, these are the choices of aortic cannulae that we have. These are the cannula which we put into the patient's aorta. And as you can see, it comes in various sizes. So the size is dictated by the size of the patient and the flows that are required. So these are venous cannula, and they're used to divert the blood, the venous blood, into the cardiopulmonary bypass machine. And generally, like I told you, we put it either in the SVC or IVC. Sometimes it can be even a single line in the right atrium. So under gravity, blood from the venous cannulae goes into the venous reservoir. So this is the Cardioplegia cannula. So cardio is heart, plegia is to paralyze. So we need to stop the heart to achieve electromechanical quiescence. So there should be no electrical activity. There should be no mechanical activity of the heart. To achieve that, we need to give a solution called as the Cardioplegia solution. So for which we need to give that solution through a particular cannula. So these are the cannulae which we use to deliver cardioplegia to the patients.